During the contour thread lift 1, the deployment port is also the anchor port for the new Articulus series CT400 thread. An intratracheal access and anchor point is made either with a 1.5 millimeter punch biopsy that facilitates adequate exposure and minimizes hair being drawn into the incisional access port, or you can use a knife or a pair of scissors. The punch is made down through the scalp to the galea. The second step, one arm, one deployment needle of the Articulus thread is inserted into one or the other side of the access and anchor port. The needle is passed down to there is resistance and then lifted up until you're in the subcutaneous supragaleal plane. With a zigzag pattern, the deployment needle is passed down through the subcutaneous space, exiting just above the brow roll, the fibrofatty brow roll, and the needle is withdrawn until all the barbs have exited into the deployment and anchor port. That leaves the 2-inch clear polypropylene anchor point cephalic exposed. The second phase, the second arm, the deployment arm of their Articulus CT400 thread, is passed into the opposite side of the deployment and anchor port, passing in the same subcutaneous plane with a zigzag deployment fashion until you get to the superior aspect of the brow roll. Exiting at that point, the needle is withdrawn until all the barb segments are under the skin. Pull back to ensure that the polypropylene contour thread is engaged, and then advance both needles so that the anchor loop is passed under the deployment port. If you have deployed the needles correctly, you have grabbed some deep tissue, galea or pericranium, and there will be a solid anchor fixation at the superior aspect of this deployment port. Other maneuvers that you can do to prevent cheese wiring: you can use a little Gore-Tex tab at the superior aspect of the anchor point to minimize the risk of cheese wiring at this clear polypropylene location. The advantages of the Articulus CT400 as outlined in the instrumentation are ease of passage, minimization of the need for tying knots, and the subsequent problem that some patients experience with knots under the scalp. Once one has deployed the correct number of Articulus CT400 threads in the brow, soft tissue dissection is performed using one of the sharp point dissectors. One can make slits with an 11 blade in the pretracheal area and make a dissection plane in the subcutaneous space between the galea and the skin between the ends of the Articulus thread. Dissection is performed until there are no more vertical fibers left attaching the skin flap to the underlying frontalis. That will complete the dissection and allow that superior skin flap to mobilize over top of the underlying frontalis. Once adequate soft tissue dissection has been performed, you grab both ends of the Articulus barbed polypropylene suture. The cogs on this Articulus thread are all pointing towards the anchor point, the smooth, non-barbed segment in the deployment and anchor port. You slide the mobilized brow flap. The mobilized brow flap. You have dissected both medial, central, and lateral to all limbs of the Articulus threads, and you mobilize the skin flap superiorly. As you move the skin flap superiorly, you elevate the brow, and you impale that skin on the superiorly pointing cogs or tines on the Articulus CT400 suture. This provides the temporary stabilizing fixation for the brow skin flap until it undergoes cicatricial autogenous fixation and wound healing that provides the long-term fixation for elevation of the soft tissue. For cheek and face elevation, a similar deployment and anchor port is made for each Articulus thread that is planned, either using the 1.5 millimeter punch biopsy or a small iris scissor or knife. Clear enough tissue down to the temporoparietal fascia to allow adequate deployment of both ends of the Articulus thread. Pass each deployment needle of the articulus thread and opposite ends of the deployment and anchor port. Grab a deep bite of the temporoparietal fascia and then elevate up into the subcutaneous space, passing in a zigzag fashion, sinusoidal fashion, down to the pre-planned exit point on the medial face. Those exit points will be lateral to the nasolabial and labiomental fold. One must decide whether you need 2 or 1 articulus thread. Each articulus thread has 2 limbs. The most common deployment pattern is using 2 articulus CT400 threads with 4 limbs. 2 will elevate the malar fat pad and lie above the commissure and lateral to the nasolabial fold, and 2 below the commissure, lateral to the labiomental fold. After you have deployed the articulus threads and you advance the needles and cut the needles off, all the cogs will be lying under the skin. The smooth anchor points between the 2 polypropylene articulus strands will be anchored in the temporoparietal fascia. Then, through slits between each articulus thread, take one of your sharp point dissectors and dissect the subcutaneous plane, the exact same level as you have passed the articulus deployment needle. Do not disrupt the path or the tunnel in which the polypropylene lies, but dissect between the arms of the articulus thread. Elevate superior to the superiormost articulus thread between each articulus thread, and then in the space between the preauricular area and the last articulus limb. Finally, grasp onto the ends of the articulus thread, take the elevated cheek and face flap and advance it superiorly along the polypropylene suture. As you advance, you impale the skin flap, the mobilized skin flap, onto the barbs of the articulus CT400 thread. Superior mobilization of this elevated flap is secured by the fixation system, the CT400 articulus thread. The thread will act as a temporary fixation system until autogenous wound healing provides cicatricial fixation between the elevated skin flap and the underlying deep tissue for long-term control of your thread lift result. For cervical CT1 elevation, a retromastoid pretrichal access, deployment, and anchor point is made either with a 1.5 millimeter punch, iris scissor, or a knife. Cervical elevation is facilitated using the CT200 contour thread, which is FDA cleared for the neck at this point in time. At this point in time, the articulus CT400 is not FDA approved, although many physicians do use it off-label. If you're using the CT200, deploy each individual needle through the same deployment port as if it was an articulus CT400 thread, one on one side of the deployment port and one on the other. Again, grabbing some deep tissue, the investing cervical fascia over the mastoid, and advance in a sinusoidal fashion to your pre-planned exit points, just lateral to the midline between the tracheal groove and the anterobortal sternocleidomastoid. Once you have advanced the contour CT200 thread until all the barbs are underneath the skin, cut the deployment needle off, leaving a couple inches along medially on the neck. Hold the proximal ends of the CT200 thread, and through a small central slit, take one of the sharp point dissectors and dissect the soft tissue off the overlying sternocleidomastoid and platysma to facilitate a freely mobilized cervical skin flap. Because the CT200 is not an articulus with a central non-barbed anchor point, you must provide fixation for the CT200. 4 surgeon's knots tied securely into the base of the deployment and anchor point provides fixation. Elevate the skin flap and bury the knot deeply under the tissue and pass the fixation needles deep to that point to hold the knot down as deeply as possible. One of the common complications of the CT200 thread is irritation, prominence, or exposure of the knot itself. Once you have secured fixation, grab the ends of the contour CT200 thread and lift and elevate the cervical skin flap if you're freely mobilized and move it posteriorly and superiorly, impaling the skin flap on the barbs of the contour thread, facilitating fixation of this mobilized vascularized neck flap. Once you have secured adequate mobilization of the brow, cheek, and neck flaps, cut the contour thread flush to the skin, allowing a retraction of approximately 1/4 to 1/2 inch of the thread itself. For enhanced predictability of flap elevation, either in the brow, the face, cheek, jowl, or neck, you may perform what is called sequential contouring. Leave approximately 1.5 to 2 inches of the distal contour thread long, clean the exit site, and tape down the contour threads. See the patient back daily for 2 to 3 days, and each time the patient visits, do a contouring maneuver on that area of the brow, cheek, jowl, or neck. This will ensure repeated superior elevation of the elevated vascularized flap. And over time, that 2 or 3 days of sequential contouring, fibrinous deposition along the elevated and dissected tunnels will decrease the tension load on that elevated flap, decreasing the reliance on the contour thread. On the morning of the 2nd, 3rd, or 4th day, whenever there appears to be enough adhesion along the elevated and dissected tunnels, then cut off the distal ends of the contour thread in a standard fashion. This technique, called sequential contouring, will help facilitate more predictability in the elevation effects during your contour thread lift 1 procedure. Basic science of the CT1 thread lift. If we come in nice and tight on the face and the neck, we can talk about what our operative plan is. We are going to deploy the right number of threads in the right zone and perform the right maneuvers to get the best skin lift we can get. And in each zone there's a different therapeutic basic science. In the brow, we've got the skin flap. The skin flap is really a glide plane over top of the frontalis, and our job during a CT1 procedure is to free up that glide plane by tissue dissection. So we're going to free up by tissue dissection with a sharp point dissector the brow. We free up that subcutaneous brow. We lift the skin flap over the muscle and we hold it there with the contour threads, with the articulous contour threads. That is a knotless type suture with 2 deployment needles that we'll be seeing in the operative experience. So we create a subcutaneous brow lift, we elevate and impale. That skin will heal to the frontalis, and that cicatricial contraction of the subcutaneous brow lift is what gives us the long-term result. So the threads are merely the fixation tools or the internal fixation apparatus to hold that brow in place, while the subcutaneous brow flap that we're going to elevate heals to the underlying frontalis. In the midface, our aesthetic goals are to bring the fat pad, the cheek fat pad, back up to this orbital malar groove where she has some dark circles. She's got a large cheek fat pad that would look lovely if it was a little bit higher up on the malar eminence. So our goal is to elevate the cheek fat pad. In order to do that, we are going to again deploy the right number of threads in this zone, which is typically 4, and then 2 coming out from under the earlobe, framing the jawline, 2 pulling posteriorly, 4 pulling superiorly. After we've deployed those 4 threads in the face, 2 in the jawline, we'll do extensive soft tissue skin flap dissection. Again, basic science of the CT1 procedure, and for the composite procedure, in fact, for the CT1 and composite is to create soft tissue undermining, to create a vascularized flap, the face, which is then advanced up the contour threads and impaled. And by elevating those flaps, it's the autogenous wound healing in those tunnels, the facelift tunnels and the jawline elevated tunnels, fibrinous deposition initially leading to long-term cicatricial collagen formation that holds that face in its elevated position. I think that we will have far higher recurrence rates in thread lifting if we do not create undermining and vascularized flaps to get repositioned for autogenous wound healing. Now, in the upper face in CT1, you want to recruit that lovely cheek fat pad. So we'll be showing you a technique where you come down subcutaneously, and by staying in the same safe plane of subcutaneous needle deployment, you can elevate the cheek fat pad and slide under it and roll that cheek fat pad over the malar eminence of the zygoma to get a nice elevation, even with a CT1 procedure of that malar fat pad, and bring those cheeks back up to a more rejuvenated oval appearance rather than the bottomed out inferior triangle. We turn that face back to an oval. Along the jawline, we're going to elevate a skin flap again. Once we deployed our 2 threads, one above and one below the jawline, so we're going to create one contour thread, one articulous thread that comes above, one below, and we are going to elevate that skin flap off platysma and slide the skin flap posteriorly and have it posteriorly adherent to the underlying SMAS and platysma. And that wound healing, that scarification, is what's going to provide the long-term control for her jawline. Same in the neck. We're going to free up the neck skin off the platysma and posteriorly off the cervical investing fascia over sternocleidomastoid and slide that skin posteriorly. And by impaling it on the fixation system, the contour threads, we're going to stabilize it while it undergoes autogenous wound healing and scarification, which gives the long-term control of the CT1 thread lift. So throughout the entire face on CT1, we elevate a brow subcutaneous flap, we elevate a facelift flap, jowl and neck lift flaps. We slide the elevated flaps or do advancement procedures of the elevated flaps and retain them with the barbed contour articulous threads, and that wound healing while it's being reduced and maintained by the threads is what provides long-term control. The second trick we're going to see in the operating room is the use of tissue adhesives. That's another opportunity to provide autogenous fixation using fibrin glue during the time of healing to minimize bruising, and we'll also demonstrate that maneuver. Finally, during the CT1 procedure and after, if you deploy what I call sequential contouring, leaving those whiskers long, leaving the ends of the articulous contour threads long, and then sequentially contouring on a daily basis, sequentially contouring, every day bring them back, hold on to the contour thread and recontour the face and the brow. By doing so, we continually reduce the face and the brow. If there's been a tendency to relapse over the first 4 or 5 days, reduce it and allow the fibrinous deposition in those tunnels you've made to decrease the strain, to provide a decreased strain gauge on the elevation. And what you'll find if you do it daily for 4 or 5 days, by the end of the 4 or 5 days, you get a stickiness, a real adhesion and a stickiness, and far less recurrence of your contour thread lift procedures by sequential contouring. So critical factors in the basic science understanding is the deployment of the right number of threads in the right trajectory and the right depth, absolutely. Subcutaneous flap elevation with tissue dissection using the sharp point dissector, absolutely. Allowing the patient the best result by offering them sequential contouring in the postoperative period, and possibly the deployment of tissue adhesives like Tisseel, like fibrin glue during the operative experience. Those factors will allow you to get the best possible result for your Contour One thread lift patients.